Okay. Good morning, everyone. My name is Olu. I'm one of the fourth year graduate and resident. Woohoo! I'm so excited, to be giving my senior lecture. Um, well, without you wasting time, I'm just gonna go right into it. Okay. Um, my senior lecture, it's actually based on November 3rd, 2020. And I'm going to be talking about, who you should vote for and why. I mean, thank God, the senior lecture topic are no longer, pre-screened. So, I get to talk about this. Uh-oh. I know everyone is so tense right now. I would not be talking about, who to vote for or anything like that. But at least now that I have your attention, so I can go into my senior lecture proper. So I would be talking about Handoff, which some people, call sign out, and, taking ownership of the new patient in the emergency department. And I would like to give a quick, shout out to Dr. Silverberg and Dr. El Fatihi for helping, to review this lecture. Brief objectives of what I'll be talking about, overview of, what Handoff is and why we do it, and the transition point in the emergency department, the types of patients involved, and the roles and Handoff, the importance of reassessment, and with some cases, and JCO mandate and IPASS, and then the takeaway point. And I haven't mentioned IPASS. I'm sure Tahir and T3 are so excited, right now. So, I mean, Handoff is actually considered one of the very high risk encounter in the emergency medicine, pretty much, due to potential for breakdown in communications for a lot of reasons. Either the information considered important is not, provided, or even when they are provided, they're not, quite understood in the context of the patient, or the information is just simply forgotten. So malpractice literature actually cites miscommunication in Handoff as responsible for 80% of medical malpractice lawsuits. Like the sentinel events actually happen in the ED and then is carried on forward. So why do we transfer care? Well, one, I mean, for obvious reasons, patient care sometimes can last longer than a typical shift. Imagine you're working 8-hour shift and you get off at, let's say, 3, and the patient comes in at 2 p.m. with the stroke-like symptoms. Obviously, you're not gonna finish, working up that patient by, the end of your shift. So you have to sign it off to the oncoming team or the physician. Like we said, there are multiple patients to be evaluated in the ED. You are continuously seeing patients. So the one that you pick towards the end of your shift, you're not going to finish, working them up, and those get signed out. Disposition requirement is another one. I mean, you're about to discharge a patient and then you find out that they are, not that you found out, that they can't walk, either they're bed bound and stuff like that, and then where we work. You need to get either an ambulance or an ambulance, to transfer them back home. And they're gonna need that paper filled out. And sometimes if it's overnight, the ambulance don't come until 7 a.m. in the morning. So if your shift, ends at 11, for example, you're not gonna stay in the ED the entire until 7 a.m. To have these patients discharged. So those patients typically get signed out. Or maybe you already have the paperwork ready, and then there's a change in patient status. For example, you've seen a seizure patient. They had a seizure at home, maybe not compliant with meds, maybe they are compliant with their medication. They came to the ED. The entire observation and blood work and imaging, what have you, that you did were all normal. And just when you're about to discharge the patient, they had another seizure. And this is towards the end of your shift. I mean, at that point, you may need to maybe do some further investigation, but that kind of patient, you're not going to stay, and I mean, extra hour to kind of like figure things out. So they will also, get signed out. And there are a lot of other reasons why we do it. So what are the transition points in the emergency department? There are typical, 3 typical scenarios. One is, change of shift. when one emergency physician shift is over, another one comes in, and then we sign out all the active patients. The other one is at the time of admission, when you've cared for a patient, you found something that they needed admission for, then you have to sign out to either MAR or the medicine attending senior with the new system that we have. Another one is at the time of transfer, like they were just talking about. Let's say we have a patient, and the services that they required is actually not offered at our hospital, or the consultant don't think this patient needs to be admitted here, then or you probably wind up transferring this patient to a different hospital, and then you have to talk to the physicians over there. So that's another transition point. So the types of patients, that we actually hand off or that we turn over, at shift change. So bulk of my lecture or senior lecture would be focused on actually the end of in the emergency department, not necessarily admission or transfer, although the process is pretty similar. So I'm just gonna keep it to the ED since that's where we work most of the time. So there are two typical patients, that we turn over. One is what is called simple action patient, and the other one is complex patient. So with the simple action patient, um, this typically requires like one or two straightforward actions, such as maybe somebody just waiting for a chest X-ray or ankle X-ray that you have low suspicion of finding anything there anyways. But for whatever reason, let's say there's trauma code and they're not taking any patient right now, you're in fast track or even in the main, and you just think maybe you just want to get a chest X-ray to make sure patient don't have pneumonia, and otherwise their vital signs is normal, they look well, you didn't even send any labs. You're not going to wait at 2-3 hours for trauma to be over and get a chest X-ray, so you may wind up signing this patient up. And even if they do have, like, let's say simple pneumonia, they still get to go home, maybe just with antibiotics. So I mean, given where we work or the nature of our department being a residency program, we don't have to worry much about this. And I've seen a lot of these at sign outs where the attending, when we round, the attending says, "Oh, this person just waiting for chest X-ray. You can keep it under me because there's a resident on the case. We'll do the normal thing." But if the chest X-ray is grossly abnormal, meaning like multifocal pneumonia or something, for that patient, then you may want to admit. And the sign out typically goes, if it's just something simple, keep it under me, discharge. But if it's, let's say, something complex, then the attending coming in takes over, and they do more thorough dive into the patient's presentation. So complex patient, this requires like significant attention from the oncoming physician. The potential for decompensation is particularly high. So these are actually patients that you will sign out, we call them active patient, that you will sign out, to the oncoming physician. So, I mean, some of us will be getting jobs, at a community place where they may not have residents, so it would just be you and another attending. So in those cases, I'm not sure whether you're gonna have something called simple action patient, where you kind of like tell someone to keep it under me kind of thing. And if X-ray, it's this or that, and then, based on the findings, then the disposition to follow. Because the reason, like we've talked about today, like malpractice stuff, who's actually responsible in a community setting where there's no resident following the case, is just attending to attending. And I said, keep it under me, unless that, do you really, I don't know, do you, for lack of a proper term, do you really trust that person to say, if this, that, and, so you may just want to keep it an active person that you sign out to them so they can take ownership of that patient. So I've kind of like divided it up in a little bit. Like what are the roles of the emergency physician that's handing off the patient to an oncoming EP, and and whatnot, things to do and things to not do. So one of them is, don't be in a rush to leave the emergency department. Like sometimes maybe people have dates, you have children to pick up at the daycare or something at 3:30, and your shift ends at 3. Because when you rush, you tend to skip over the information that may be, crucial to that patient presentation, and we just kind of like skim over everything. And the oncoming physician really have no idea of what's really going on with the patient, and then that creates a potential for error. What some ED department have done in terms like this is, or what they recommend sometimes is you can actually make an arrangement, with the oncoming physician. Maybe they can come a little earlier, an hour early, depending on what you both agree on. An hour early, maybe even 2 hours early, if you feel like you have an obligation that you must go to right after, your shift is, ended. So if that person comes, let's say an hour, 2 hours early, so they can relieve you on time, and then you get to pay them back at some other pre-arranged, time for their 2 hours or something. So another crucial thing is to communicate, like you want to talk about the existing needs, of that patient, and, even what to anticipate. Like if it's somebody, for example, that you think, is they may have appendicitis and you've ordered, let's say CAT scan, for example, let the team, the person coming on know that that is your worry at that point. And, to keep an eye on the CAT scan, because these patients may need antibiotics sometimes, depending on what it is. Pneumonia, for example, they want you to get an antibiotic on within an hour of ED presentation, things like that. So they can really keep the time and not do it 2-3 hours later. And you really want to discuss the plan of care. Like, in my in-depth, research, I've seen this happen a couple of times. It's not enough to just say, oh, this person is here for abdominal pain and I'm getting a CAT scan, and just follow the CAT scan. There should be a really like detailed plan of care. Like for example, if the CAT scan is negative and you reassess the patient and they're no longer in pain or something, then you can discharge them. Or if the CAT scan is positive for A, B, or C, then consult the appropriate, even though it sounds redundant, but consult A, B, C, or something like that. Like there should be a detailed plan of care. Not like you just leave it up to the person coming, like, do whatever you want, which is what they'll probably do anyways. Um, Describe any potential complications that could arise. For example, in CCT, some guy came in hypotensive, you've done your push those pressors and things like that, and you feel like they need a central line, and you've just put in a um, subclavian line, and you order the portable chest X-ray that's not yet done, and now we are rounding. Even though the incoming physician may know, but you should still communicate with them to keep an eye on that chest X-ray to make sure, get it done on time, to make sure there's no pneumothorax and hemothorax and complications, light of the procedure that you just did. You want to document, transfer of responsibility in the medical record. It's not enough that you just say it, verbally, to the person. You should also document, like, at this time, care of so X and X patient is now in the hand of Dr. X and Y. You also want to inform the patient and or their family of the change in, the physician. Like you should not just, rush out after sign out. Take time to like walk, to the active patient, at least the one that are still active. Like, the shift is over, you've transferred. I know we do it right in front of the patient because we work in the room, but actually a one-on-one conversation with them, like, your shift is over, you are signed out to Dr. X and X, and these are the expectations. Patients sometimes may have last minute, question about their care, or about something in particular that you did before, that they may ask Dr. X, that just came in, and he may have no clue, or, you the one that took care of them, before, so you have better answers for why you did, X and Y. And also update, the nurses, taking care of the patient. I know we do sign out, they see us sometimes. I mean, some places, the nurses also actually are part of the end of, process. Like they follow and talk, they know what the plans are, what the patient is waiting for and stuff. But we don't often do that at county. So at least, update the nurse, they sign out. This is why they're still here. They're waiting for the CAT scan, and the doctor will follow that if it's abnormal, this, that. So the nurse is also aware of what's going on. So what are the roles of the physician coming in? So, I mean, this can be a bit weird sometimes. I've experienced this in my very little short time at county. Is to ask questions and, or clarify some things or information that you've been presented with, during sign off. And sometimes I feel like the outgoing physician sometimes, well, it can be a bit weird sometimes when you feel like this person coming in just keep digging and digging and digging for questions, like sometimes you feel like they haven't listened to what you've said. and it's like they have, you know, certain questions that they just wanted answered. Even sometimes you've actually said those things, you know, in the thing. So which will lead me to iPass, you know, sometimes, you know, a way of like standardizing what is, you know, passed over, and then, you know, the incoming person also get a chance to recite or kind of like summarize, you know, what they've heard. You want to understand what what the expected course in the ED is. You know, when they sign out a patient, what are they saying? Are they saying this person is going to get a CAT scan, and even if the CAT scan is normal, the patient should still be admitted anyways, you know, due to X and Y? Because if you don't understand that and you just get a call an hour later or 30 seconds later and the CAT scan is normal, you may discharge the patient, not realizing that whether CAT scan is normal or abnormal, that the patient should still be admitted. So you want to make sure that you understand, you know, the expected course. I can't stress this, you know, enough. As you need to assess, pretty much assess everybody. I know here in the slide it says complex patient, but I think the point of this is, if possible, to do it while the off-duty physician is still around, because there may be something that wasn't communicated that you found, you know, your assessment that you may want to clarify with them, or something like that, or something that they ordered. Maybe you felt something else, you know, needed to be ordered or something. You can clarify that information. And lastly, is that you accept ownership, you know, for those particular patients. Don't assume anything. You have to review everything. I know, you know, you are passed on certain information, but you should still confirm those information in the patient's, you know, medical record. What was ordered, what was done, what were the findings, the labs, the EKG, even the ACR. And I learned this, you know, from Dr. Glazer a couple of times, you know, like, and you know, county patient came by EMS, you look up the ACR report, is not there. They typically comes minutes or sometimes hours later. And when you pretending, or, you know, even regular shift, you present a patient to him, and then he goes, what's the ambulance report says? I'm like, oh, it's not there. So he double check himself right there, and then he finds it sometimes. Most times they're not, still not there. But then you read something out that you weren't aware of, or that at least I wasn't aware of. Oh, patient, maybe some psych, you know, issues there. What do you think about this? I said, well, I mean, I didn't know about that, or the ACR wasn't there when I saw the patient. Then we get to go back and clarify those things, and then document appropriately as well. You can imagine discharging the patient when there's something in the ACR that says this patient is homicidal or suicidal, and you didn't get that information from either the triage nurse or from your assessment of the patient. So it's good to review all these things. And also, like, go to the patient side, bedside, introduce yourself after you've reviewed, you know, their summary, their findings, their labs and stuff, and tell them what you know so far about why they're there, and let them fill you in if there's anything different. And then they get to ask questions, and you also get to update them about their findings so far. And then, you know, someone said, you know, take care of the patient as if no one else had been involved in their care except you. Meaning, do it like you've seen the patient anew. I know it's time consuming. We have too many people waiting. Like, it's easier to just take a sign out, just follow whatever is said to follow, and just discharge, you know, sometimes even without going. I remember my second year, third year actually, in observation, and I got a couple of sign outs, and one was if troponin is at negative, just placed on OBS for ACS workout. And when I was signing out to the OBS resident, and it was just, oh, this person here for if troponin, the sign out was if troponin is negative to place on OBS, so we put in an OBS. And the question was, did this person get aspirin? So I assumed, well, if they're going to the OBS, they must have given aspirin. So I said yes. And then the person reviewed it, said, I didn't see any aspirin ordered. And I checked myself too. And I said, oh, sorry, it wasn't ordered. Then I'm just going to give it now. So that shows, you know, that I really didn't take, you know, ownership of that patient. I didn't review anything. I was just going by what I was told, you know. So you really want to review, make sure you know this patient in and out. And another encounter that I've had, you know, in the person of Dr. Joey Friedman, was whenever we round in, and you start off with, oh, this is a sign out, or this patient was signed out to me, his immediate response is usually, do you mean to tell me you don't know anything about this patient, or you don't really know this patient? Because if